Alright, so we're going to talk about some microbiology today, baby. The bacteria. So let's dive right down into them. Actinomyces israelii. He is a gram-positive rod that forms long, branching hyphae or whatever, the same as nocardia does. He's a facultative anaerobe versus nocardia, which is an obligate anaerobe. He's part of your normal flora. But in the setting of dental manipulation or disruption of mucous membranes, actinomyces can cause chronic oral facial abscesses that drain via the sinus tracts. So this can form an abscess producing a hard lump, often on the jaw, which comes from the common name of this condition, lumpy jaw. So if you see that anywhere in the vignette, that's a straight up giveaway for Actinomyces israelii. It's also a normal colonizer of the vagina and the colon. Now, the sinus tracts classically have these yellow sulfur granules surrounded by purulents and neutrophils. That is important. They love to test you on the yellow sulfur granules for some reason. You treat this guy with penicillin and amoxamine. Excess sinus tracts if needed. You can excise the sinus tracts if needed. And a way to remember what you treat what with between actinomyces and nocardia is sulfonamides go with nocardia, and actinomyces you always go with penicillins. So that is Actinomyces israelii for you. Let's go on to Bacillus anthracis. Bacillus anthracis is a gram-positive rod, aerobic, and is spore-forming. Now, spore formation is protective and occurs when nutrients are limited. Besides Bacillus, the only other spore-forming rod is Clostridium. Also, like Bacillus, Clostridium is gram-positive. However, Clostridium is an obligate anaerobe, where Bacillus is an aerobe. Now also notice that Bacillus has a poly-D-glutamic capsule. Bacillus anthracis is the only bacteria with a protein capsule. The only bacteria with a protein capsule. So that makes it quite significant. Now you can have cutaneous, I forgot to write that in there, contact. Contact cutaneous anthrax, where it's usually a painless ulcer and vesicular papules covered with a black eschar node, and that untreated cutaneous anthrax is fatal in about 10 to 20% of the cases. Now you can also have inhalation anthrax, which gives you flu-like symptoms that progress to pulmonary hemorrhage and shock. Now GI anthrax occurs after eating undercooked or raw meat from an infected animal. You get flu-like symptoms that progress to sore throat, difficulty swallowing, nausea, vomiting, and diarrhea. Now the anthrax toxin is a protein exotoxin that may consist of either one of two dimers. Number one, PA, which is the protective antigen, plus edema factor. Or, number two, protective antigen plus lethal factor. Okay, it's the lethal factor that kills you. So how do we prevent gastrointestinal and inhalational and cutaneous anthrax? Well, we use the toxoid vaccine. The toxoid vaccine will help prevent these forms of anthrax. Alright, so Bartonella henselae. What do we know about Bartonella henselae? Well, he's a pleomorphic gram-negative rod that is part of the oral flora of, you got it, cats. and he causes bacillary angiomatosis and cat scratch disease in humans. Now, the main mode of transmission is biting or scratching from a cat, so human to human transmission is unlikely. And usually the immunocompromised patients, like the aged patients, they're the ones that get bacillary angiomatosis. This is capillary proliferation that resembles Kaposi sarcoma. Kaposi sarcoma on the skin and visceral organs. It's usually not cultured in the clinical setting due to the length of growth time required. Clusters of tangled bacilli can be visualized upon normal tissue biopsy with a Warthin starry silver stain. Warthy starry silver stain. Alright, so how do we treat Bartonella henselae? Well, we treat it with doxycycline, which you'll see we treat a lot of things with, or erythromycin. Now, in the immunocompromised or the immunocompetent patient, that's the one where you get cat scratch disease. Now, this causes localized lymphadenopathy in a person with a recent cat exposure. So cat scratch disease causes localized lymphadenopathy. In persons just around a cat. The lymph node biopsy shows distinctive histology due to Bartonella presence, so the Warthin silver stain will not reveal an abundance of organisms in an immunocompetent patient. Symptoms are usually mild. Antibiotic therapy is not recommended, and the disease will dissolve on its own. So that's cat scratch disease. Although if you have a compromised immune system, such as in age, this cat scratch disease can lead to bacillary angiomatosis. So aged patients need to be warned to stay away from cats. So what about Bordetella pertussis, or whooping cough? Good old whooping cough, the causative agent of the pertussis, or the whooping cough. He is a strict aerobe, he's oxidase positive, he's non-modal, and is an encapsulated gram-negative rod. An encapsulated gram-negative rod. You culture him on regal low or Bordetella media. Bordetella media. Now the reservoir is vaccinated humans over the age of 10 years. Although the immunity developed in response to an actual pertussis infection is lifelong, immunity induced by the DTaP vaccine, primarily IgA, lasts for only 5 to 10 years. So transmission is through person-to-person spread via respiratory droplets. Okay, it's through respiratory droplets. There's no known reservoir for Bordetella pertussis other than humans. So the pathogenesis is that it attaches to the mucosa of the nasopharyngeal ciliary epithelium via the pertussis toxin and filamentous hemagglutinin. So the toxins mediate mucosal damage. So there's 4 toxins. Number 1, you have an exotoxin. Number 2, you have the pertussis toxin. Number 3, you have the adenylate cyclase toxin. Then you have the tracheal toxin. Alright, so the pertussis toxin is an A-B exotoxin that, number 1, ADP ribosylates the GI by removing the ADP ribosyl group from NAD and covalently attaching it to GI. So therefore that leads to GI inactivation, which causes an increase in cyclic AMP, which causes an increase in the secretion of sodium chloride and water from cells, so we get edema and neutrophil dysfunction. Now, number 2, the pertussis toxin inhibits chemokine receptors, so you get a lymphocytosis. The lymphocytes cannot enter the lymphoid tissue, so that's why that happens, and therefore they remain where? In the blood, right? Number 3, it activates pancreatic islet cells, so you get an increased insulin release, and that's why you see hypoglycemia with the pertussis toxin. And number 4, you get an increased sensitivity to histamine, so allergic reactions are quite common. Now, the adenylate cyclase toxin that converts ATP to cyclic AMP causes a decreased leukocyte chemotaxis, and you get a decreased phagocytosis. The tracheal cytotoxin kills ciliated epithelial cells, which prevents cilia from clearing debris from the lungs, so you get a coughing fit because of it. Now, the cough with the inspiratory whoop is the classic presentation of whooping cough, and hence that is inspiratory. Okay, so the infection with Bordetella pertussis is now rare in the U.S. due to the DTaP vaccination. However, infections with Bordetella pertussis should be considered in unvaccinated children and afebrile adults, which are greater than 9 years old, with a cough for greater than 2 weeks. The vaccination is a cellular vaccine that is usually given as a part of a combination of vaccines. The DTaP vaccine is for infants and children, and the TDAP booster is for adolescents and adults. And how do we treat this? We treat it with macrolides, so azithromycin, clarithromycin, ezithromycin. They may prevent the disease if given during the catarrhal stage, or they may decrease bacterial shedding but do not alter the disease course if given during the paroxysmal stage, which is the severe coughing stage. So if you can get it in the catarrhal stage, use the macrolides to treat Bordetella pertussis. I'll write that in there. Alright, and that's Bordetella pertussis for you. So what are we going to talk about next? We're going to talk about Borrelia burgdorferi. Hopefully I said that right. So he is a spirochete. That is important, you need to know. Can you name some other spirochetes for me? How about Trypanon spellitum, that causes syphilis, or Leptospiriliae? Anyways, Borrelia burgdorferi is transmitted by the Azodes tick bite. That is high yield. You need to know that. It's a tick that must be attached for 1 day. Now, the Borrelia reservoir is mice. That's the reservoir. White-tailed deer, however, are the intermediate hosts and are needed for ticks to reproduce. So they're most commonly transmitted during when? During the summer months. That's when you usually see Lyme disease. Now, Borrelia burgdorferi causes the Lyme disease. Now, the signs and symptoms of Lyme disease can be remembered with the mnemonic BAKE. For Bell's palsy, arthritis, cardiac block, but this would be probably needed to be a K for BAKE, and erythema marginatum. That right there is the signs and symptoms of Lyme's disease. Now, stage 1 of Lyme's disease is erythema migrans, fever, headache, fatigue. Note, the erythema migrans is the pathognomonic bullseye rash of Lyme's disease. That's erythema migrans. Usually has a central dark surrounded by a white ring, surrounded by the outermost red ring, and it expands outwards. It's warm and usually non-tender. That's stage 1. Now, stage 2 of Lyme's disease is when they get Bell's palsy, meningitis, cardiac involvement, most commonly what valve? Most commonly the AV valve, or most commonly the AV block. I'm sorry, not the AV valve, the AV block. So they're going to get heart block. In stage 3 of Lyme's disease, that's when they get arthritis, usually in the knees, or migratory polyarthritis. That's stage 3. So what do we use to treat it? We use doxycycline and ceftriaxone. Doxycycline and ceftriaxone. And that's pretty much the Borrelia burgdorferi for you. So what about Campylobacter jejuni? Well, he's a comma-shaped, oxidase-positive, gram-negative rod. Gram-negative rod. He's a microphilic, so he grows best at about 42 degrees Celsius. His reservoir is domestic animals. Domestic animals like dog, poultry, cattle, etc. So transmission would therefore be fecal-oral. Fecal-oral or ingestion of contaminated meat. Now, Campylobacter jejuni is one of the most common causes of bacterial foodborne disease and is the leading cause of bacterial diarrhea in the United States. So you think they're going to test you on this on the boards? You better believe it. What it does is it colonizes and often invades the terminal ileum and the colon, and it may release toxins. So you get inflammatory diarrhea characterized by white blood cells in the stool that is initially watery and foul-smelling, then bloody. Okay, that's Campylobacter jejuni. Campylobacter jejuni infection can be confused with what? Ulcerative colitis and Crohn's disease. So you need to have Campylobacter jejuni on your differential when you hear ulcerative colitis and Crohn's disease. So very good. Campylobacter jejuni commonly precedes a Guillain-Barré infection. Now, Guillain-Barré is the most common acute peripheral neuropathy and the most common cause of acute flaccid paralysis. Endoneural inflammation and segmental demyelination occur. Therefore, it is symmetric and it's ascending muscle weakness paralysis, talking about Guillain-Barré. So, in addition to Campylobacter jejuni, infections with the associated Guillain-Barré include H. influenza, herpes virus, which is the CMV, EBV, VZV, and mycoplasma pneumonia, but that's not that high yield. So I just want you to know that how you treat it, or that Campylobacter jejuni infection commonly precedes Guillain-Barré syndrome. And you treat it with ciprofloxacin and erythromycin. All right, Chlamydia trachomatis. He is an obligate intracellular parasite that cannot make his own ATP, so therefore he lacks cell wall's muramic acid. Chlamydia lacks muramic acid. Now there's two morphological and functional forms. We have an elementary body and a reticulate body, 1 and 2. Now, the EB, or the elementary body, is infectious. It's metabolically inert and it can survive extracellularly. The elementary body causes endocytosis by the susceptible host, so through the actin microtubular network activation, and it survives by inhibiting fusion of endocytic vesicles or vacuoles with lysosomes versus Coxiella, which is survives inside an acidified phagolysosome and Listeria, which uses lysosterilizine O to lyse the vacuole membrane and escape into the cytoplasm. So, with these two morphological forms, back to Chlamydia trachomatis, sorry about that, you get an internalization trigger that conversion to the RB form, which was the reticulate body form, which is metabolically active but not infectious. So the RB, the retinoblastoma, the reticulate body, is not infectious. It's not infectious at all. The membrane-bound compartment is converted to cytoplasmic inclusion bodies, and RBs replicate by fission. So numerous reticulate bodies turn into elementary bodies. Cells rupture and elementary bodies infect other cells. Now, it can be asymptomatic, but it can cause urethritis and vaginitis, pelvic inflammatory disease, conjunctivitis, and Reiter's syndrome. Reiter's syndrome is conjunctivitis, uveitis, urethritis, and arthritis. So how do we treat it? Again, doxycycline and azithro or erythromycin, your macrolides. Chlamydophila species. Chlamydophila species. What do we know about Chlamydophila? He is formerly Chlamydia pneumonia and Chlamydia pistachiae. Okay. He was reclassified in 1999, or reclassified to the Chlamydophila group in 1999. So he's the same as Chlamydia trachomatis. Both are obligate intracellular parasites. Just like you see right here, obligate intracellular parasite. Now, both Chlamydia trachomatis and Chlamydia pneumonia cause atypical pneumonia. That is high yield. Okay? Both cause atypical pneumonia. Chlamydia pneumonia is transmitted via respiratory droplets, and Chlamydia pistachiae is transmitted via birds. Either through direct contact or respiratory secretions. Now, the drug of choice here we use is doxycycline for atypical pneumonia of chlamydia. So that's Chlamydophila species for you. Moving right along, we go to Clostridia. Now, Clostridia is a gram-positive Rob, obligate anaerobe, and a spore former. Now, spore forming, spores can survive normal pressure boiling. So that's why it's important that we use an autoclave, right? So we have two things here. We have Clostridium tetani and Clostridium botulism. We also have Clostridium perfringens and Clostridium difficile, but the two I want you to pay attention to is Clostridium tetani and Clostridium botulism. So Clostridium tetani, you get the tetanus exotoxin called tetanospasmin. Tetanospasmin, which is a protease that cleaves the releasing protein synaptobrevin, thereby inhibiting the release of inhibitory neurotransmitters glycine and GABA. So tetanospasmin therefore inhibits the inhibitor, so you get a net stimulation. By inhibiting the release of glycine from the spinal cord and GABA from the brain, tetanospasmin causes excessive muscle contraction. So that's why you get a rigid paralysis known as tetanus. So that's when you get lockjaw, which is known as trismus. Rias sordonchius, which is ironic smile of tetanus. And also a pronounced arcing of the back, which is opthentosis, optentones. Opsistotones. Totonos, due to contraction of back extensor muscles. So what do we do to prophylax against this? Well, we use number one, the DTaP vaccine, which I've talked about numerously already. The booster. or the TDAP required every 10 years. And the treatment for Clostridium tetani, does anybody know what it is? It's the anti-tetanospasmin immunoglobulin. Anti-tetanospasmin immunoglobulin. That's how you treat Clostridium tetani. So what about Clostridium botulism? Well, Clostridium botulism secretes a neurotoxin that blocks acetylcholine release. Acetylcholine release at the neuromuscular junction. So therefore, with this guy, you get a flaccid paralysis instead of tetanic contractions like with Clostridium tetani. With botulism, you get a flaccid paralysis. That's why we give people Botox, right? Presenting symptoms include dry mouth and blurry vision, classic signs of acetylcholine blockade there, no surprise. So deaths, how do you think the deaths occur? Respiratory failure, very good. The diaphragm is a muscle, right? So adults are affected only when ingested preformed toxin, which is food botulism, causes spores that are unable to germinate in adults' mature intestinal tract. In infant botulism, babies ingest spores found in honey and other foods that germinate and subsequently elaborate toxin. Now the treatment for this guy is immunoglobulin or antibodies that bind to the toxin that is not yet bound to the nerve endings. Key there, not yet bound to the nerve endings. So to compare the exotoxins of Clostridium tetani and Clostridium botulinum, the botulin toxin or Botox and tetanus spasmin toxin both cleave the releasing protein synaptobrevin, thereby inhibiting neurotransmitter release. However, although they share a similar mechanism, these toxins affect the release of different neurotransmitters. The tetanus toxin, which cleaves synaptobrevin, inhibits the release of GABA in the brain and glycine in the spinal cord, causing a rigid paralysis. Right? You inhibit the inhibitor. Whereas the botulism toxin cleaves also synaptobrevin, which inhibits the release of acetylcholine, causing a flaccid paralysis. So what do we know about Clostridium perfringens, or the only non-motile Clostridium? The only non-motile Clostridia. Only non-motile Clostridia. There's two exotoxins here. Number one, if directly inoculated into tissue, such as example, trauma may drive Clostridium perfringens into the skin or the muscle. This is the alpha toxin, okay? Alpha toxin. Now the alpha toxin, which is a lecithinase, which is an enzyme that cleaves lecithin, is a key component of the cell membrane, so you get myonecrosis. Myonecrosis, that sounds not fun. That leads to So Clostridium difficile is an iatrogenic infection, usually due to antibiotics. antibiotics such as fluoroquinolones, ampicillin, and classically that they're going to test you on, clindamycin. But no, they could also go for fluoroquinolones or ampicillin. Now, these alter the intestinal flora of Clostridium difficile to flourish, the most common cause of nosocomial diarrhea. The most common cause of nosocomial diarrhea. Now, Clostridium difficile produces two toxins. That's exotoxin A, which is an enterotoxin, and exotoxin B, which is a cytotoxin. So the number one, exotoxin A, causes it chemoattracts neutrophils, which release what? Cytokines. So therefore, you get a mucosal inflammation and a GI fluid loss. Number two, the cytotoxin, the exotoxin B, disrupts the cytoskeleton by depolymerizing actin filaments. So you get a GI mucosal cell death. That's what gives you the classic pseudomembranous Does anybody know? Colitis. Pseudomembranous colitis. You will be tested on that, I guarantee you. And that is from the cytotoxin, exotoxin B. So don't just know that it's a toxin. It's toxin B, exotoxin B, because exotoxin A is the enterotoxin. Exotoxin B is the cytotoxin. Now, there are several tests that can diagnose Clostridium difficile colitis. They include stool culture, which is the most sensitive, but it takes a long time. You can do a glutamate dehydrogenase enzyme immunoassay, which is highly sensitive, but positive tests may be confirmed with another test. You can do a real-time PCR for Clostridium difficile gene toxin. You can do a stool cytotoxin test. You can do even an enzyme immunoassay for detecting toxins A and B, which is a widely used test. It's highly specific, but only moderately sensitive. So negative tests must be rechecked with the alternate exam. And how do we treat this guy? We treat it with metronidazole, or oral vancomycin. Metronidazole or oral vancomycin. So it's not, the oral vancomycin is not absorbed systemically. Is why we do that. And that is Clostridium for you. I know that's a lot. Corynebacterium diphtheriae. So these are gram-positive rods. They have metachromatic granules and they grow on terlite agar. Okay? So the pathogenicity of these things, of Clostridium diphtheriae, is conferred by an exotoxin encoding bacteriophage. I will. What time is it? I'll do it. Now, only Clostridium difficile strains that are infected by these bacteriophages can cause clinical diphtheria. So the exotoxin that catalyzes the ADP ribosylation of EF2. Ribosylation of EF2, thereby inhibiting tRNA translocation from ribosomal A sites to P sites. So the signs include pseudomembranes in the oropharynx, cervical lymphadenopathy known as bull's neck, and, if left untreated, myocarditis could develop. So what do we do here? There's usually a progression of the deterioration of myelin sheaths in the central and peripheral nervous system. So the signs and symptoms include blurry vision and pharyngeal diaphragmatic paralysis. So we can use the DTaP vaccine. We can also use the DTaP with the diphtheria, tetanus, and acellular pertussis vaccine as administered prior to 7 years of age. So the Tdap vaccine can be given to persons older than 7 years of age. The two products differ in dose, and the uppercase letters of DT and AP indicate a higher antigen quantity. So that's why we refer to them as different. So that is Corynebacterium for you. So let's talk about Enterococci. These are gram-positive in pairs. They are fasciculative anaerobes with variable hemolysis on blood agar. They grow on 6.5% sodium chloride, and they hydrolyze esculin in the presence of bile. Now, there's two species commonly found in the human GI tract. That is Enterococci faecalis, which is the more common type, and least likely to be resistant to vancomycin. And then there is the Enterococcus faecium, which is less common and more likely resistant to vancomycin. So faecalis and faecium. Formerly classified as Group D Streptococcus, it reclassified based on its DNA analysis. Now, it can also cause UTIs and subacute endocarditis. So, and it has high rates of aminoglycoside and vancomycin resistance. So, VRE, vancomycin resistance, and aminoglycoside resistance. That's Enterococci for you. So, E. coli, Escherichia coli. So, E. coli is a gram-negative rod. It's motile. It's a facultative anaerobe, and it ferments lactose, as does Klebsiella and Enterobacter. It's a catalase positive and a member of normal gut flora. So now there's key antigens here. And there's the K antigen. The K antigen is the capsule. The O antigen is the outer polysaccharide, and the H antigen is the flagellum. Now, O157, we've all heard this, H7, is the most commonly isolated strain of EHEC, enterohemorrhagic Escherichia E. coli, or enterohemorrhagic E. coli, EHEC. 0157H7, I want you to think EHEC. Okay? Now, strains with the K1 antigen, which was the capsule, that are one of the top 3 causes of neonatal meningitis. Neonatal meningitis, along with Listeria and Strep echolectiae. Now, strains with the P. pili can cause polynephritis. The clinical significance, it is the most common cause of UTI and gram-negative sepsis. That's high yield, definitely know that. There are two primary pathogenic strains, and that's ETEC, which is enterotoxigenic E. coli. Now, this one does not invade. It causes traveler's diarrhea. Traveler's diarrhea. So you get abdominal pain, non-bloody diarrhea. What it does is it elaborates 2 toxins that cause watery diarrhea. The LT, which is similar to the cholera toxin, it's a heat labile and stimulates adenylate cyclase. And then he's also got the ST, which is similar to Yersinia or Enterococci toxin that is heat stable and stimulates the guanylate cyclase. So traveler's diarrhea is pretty terrible. Enterohemorrhagic E. coli causes bloody diarrhea. Bloody diarrhea. It ferments lactose but not sorbitol, compared to all other E. coli which ferment both. Not sorbitol. That's a clue and a dead giveaway on the boards that they want hemorrhagic E. coli, the 0157H7, if it ferments lactose but not sorbitol. The most common strain, like I've said 3 times, is 0157H7. It elaborates the Shiga-like toxin, which is an encoded lysogenic bacteriophage that inhibits protein synthesis. Now, the toxin may enter the bloodstream and damage the kidneys and can cause a hemolytic uremic syndrome. Hemolytic uremic syndrome, where you get fever, a hemolytic anemia, thrombocytopenia, and acute renal failure. It's associated with undercooked hamburger meat. So you get outbreaks from contaminated spinach and cookie dough in recent years. So what do you think the treatment for this is? Rehydrate. That is the treatment. Rehydrate them. Replenish the electrolytes they've lost. So that's E. coli. So what about Gardenerella vaginalis? Gardenerella vaginalis. She is a pleomorphic gram-variable rod. A pleomorphic gram-variable rod with clue cells. Clue cells are epithelial cells that with adherent bacteria on light microscopy. So because she is gram-variable, what I meant by that is she's got both gram-positive and gram-negative characteristics that are seen. So Gardenerella vaginalis. Let's see. It's usually alterations in natural vaginal flora which may lead to proliferation and overgrowth of Gardenerella vaginalis, which is BV or bacterial vaginosis. Now, it leads to a thin, relatively watery, grayish vaginal discharge with a fishy odor, which becomes especially repugnant after the addition of KOH. They call that a positive whiff test. Yes, positive whiff test. Now, there is no vaginal or cervical tenderness. No vaginal or cervical tenderness. Okay, with Gardenerella vaginalis. It just smells bad. So what do we use to treat it? We use metronidazole. Bacterial vaginosis is typically associated with alterations in the natural vaginal flora and therefore is not strictly considered an STD. However, its incidence is positively correlated with the number of sexual partners and new sexual partners. So what about Haemophilus influenza? Well, Haemophilus influenza is a small gram-negative rod Bacillus. His transmission is through respiratory droplets. He's a fastidious organism. He grows on chocolate agar. Chocolate agar, which is heat-inactivated blood supplemented with factors X. Factors X, which is hematin, and V, which is NAD, which are required both for growth, right? You need heme and you need NAD for energy. So, like we said, the transmission is through respiratory droplets. There is 6 strains that have capsules. 6 strains that have capsules. Hib is the most virulent, and that is HIB. Haemophilus influenza type B. 95% of pediatric patients and 50% of adult infections with hips. So that's why we have a hip conjugate vaccine. Now, Haemophilus causes septic arthritis, epiglottitis, meningitis, otitis media, and pneumonia. Now, you treat meningitis with third generation cephalosporins like either ceftriaxone or cefotaxime. Close contacts get what type of prophylaxis? Rifampin. Rifampin prophylaxis. It achieves high bactericidal concentrations intracellularly and in mucosal secretions, so that's why we use rifampin. So that is Haemophilus influenza. So now let's talk about Helicobacter pylori. This is a curved gram-negative rod, which is urease, oxidase, and catalase positive. So this is why we use the urease breath test. Urease breath test. It creates an alkaline environment to survive in. So it causes chronic gastritis. It's the leading that lead to duodenal and gastric ulcers. It causes maltoma tumors, and possibly even gastric adenocarcinoma if not treated. Now you treat it with triple therapy such as BMT or LAC. Now the first line therapy is LAC. That's the first line. That is, change colors here. Lansprozole, amoxicillin, and clarithromycin. So lansprozole, amoxicillin, and clarithromycin can substitute omeprazole. Clarithromycin can substitute omeprazole for, or you can substitute omeprazole for lansprozole. Now the second line treatment is the BMT, which stands for bismuth, like in Pepto-Bismol, man, metronidazole, and tetracycline. And that's used if penicillin sensitive as a second line therapy for H. pylori. And that is H. pylori. So let's talk about Klebsiella. So Klebsiella is a gram-negative rod with a large polysaccharide capsule, and they call that the mucoid appearance because it's got such a large capsule. As you can see here, it appears almost mucousy. It causes KAP, which is red currant jelly sputum in alcoholics. Sputum in alcoholics and immunocompromised patients, including diabetics. There tends to form pulmonary abscesses and empyema. With the pulmonary abscesses, Klebsiella can cavitate in the upper lobes, mimicking TB. Antibiotic resistance isolates often produce extended spectrum beta-lactamases resistant to third generation cephalosporins. So these extended spectrum beta-lactamases strains, carbapenems, are the recommended treatment of choice. Now, strains not producing these extended spectrum beta-lactamases, or just ESBL from now on, can be treated with a combination of third generation cephalosporins, aminoglycosides, and fluoroquinolones. The important features of Klebsiella can be remembered by the 4 A's, and that is aspiration pneumonia, abscesses in the lungs, alcoholics, and diabetics. The 4 A's of Klebsiella: aspiration pneumonia, abscesses in the lungs, alcoholics, and diabetics. So, that is what you need to know about Klebsiella. So what about Legionella pneumophilia? Legionella pneumophilia is an aerobic waterborne gram-negative rod. It's classically transmitted in aerosol water droplets. Classically airs in water droplets. It grows on a chocolate yeast agar. Grows on a chocolate yeast agar with extracts of iron and cysteine. It gram stains weekly. It silver stains instead. Silver stains instead. Legionella pneumophilia. So it's a facultative intracellular organism. Compare this to two other main causes of atypical pneumonia, like mycoplasma, which is extracellular, or Clostridium pneumonia, which is an obligate intracellular parasite. It causes several severe atypical pneumonia, leading to also known as Legionnaire's disease, or self-limiting Pontiac fever, and flu-like syndrome, which leads to the myalgias, the fevers, but no pneumonia. So the biggest thing here is you can get a hyponatremia. Less than 130 milliequivalents per liter. This is an important distinguishing feature of Legionella pneumonia. Okay, so you get a serum sodium of around 130 instead of 140. In addition to a prominent non-productive cough, severe Legionella pneumonia can be accompanied by confusion, diarrhea, and signs of kidney damage, such as proteinuria or microscopic hematuria. So what's the treatment here? What is the treatment of choice for Legionella pneumophilia? The treatment is erythromycin. That's the classic treatment, but recently fluoroquinolones and azithromycin have been started used. But on the exam, you pick erythromycin. But even though fluoroquinolones and azithromycin have been shown to be more effective, so you read the question carefully. Do I choose erythromycin or azithromycin? You know, there's better shown evidence, so I would actually, no, I take that back. I would choose azithromycin instead of erythromycin, unless you may ask a classic treatment by what seems to be an old school question writer. Alright, so Leptospirillii interrogans. So like Borrelia and Treponema, Leptospirillii or Leptospirae is a spirochete. They are found in water contaminated by animal urine. So let's talk about leptospirosis. You usually see a fever, a headache, abdominal pain, and jaundice. You can also see conjunctival injection, and myalgias. Of the calf and lumbar spine are suggested as well. Now, Weil's disease is a more severe form of leptospirosis that includes hemorrhage, hemorrhage, anemia, and azotemia. In addition to the headache, fever, abdominal pain, and jaundice that characterize leptospirillus, that is what you will see extra in Will's disease, which is a much worse form of leptospirosis. So, every time you see jaundice, don't just run away and jump straight to the bilirubin tract, even though that's where it's usually coming from. So let's talk about Listeria monocytogenes. These are gram-positive rods found in soil and water. There's foodborne illness associated with underpasteurized milk. Underpasteurized milk, soft cheeses, deli meats, hot dogs, and raw vegetables. So they have a tumbling motility, and they are beta hemolytic versus diphtherioids. They are facultative intracellular pathogens, so they invade the host cell. Then they use Listerio-Lysin O. Listerio-Lysin O lyses the phagosome, which moves with actin-based motility within the cytoplasm of the host cell. And this spreads cell to cell without exposure to antibodies, complement, and neutrophils. So, what does that mean? We have a bacteria here, a gram-positive rod, where I'm going to see, you got it, a cell-mediated immune response. That is important. It will be tested on, I can assure you. So make sure you get it. Cell-mediated. Why? Because it's spreading from cell to cell without being exposed to antibodies, complement, and neutrophils, which are all part of the humoral immune system to get bacteria. So this is going to be a cell. This is why cell-mediated immunity is important. So let's take it to another point. So who could get a lot of Listeria monocytogenes infections? What affects the cell-mediated immune system the most? Nutrition, right? So a starving kid in Africa could definitely get this. So that takes us into listeriosis. This is the most common presentation, is bacteremia with fever, muscle aches, occasional nausea, and diarrhea. Now the bacteremia can lead to third trimester amniitis, preterm labor, spontaneous abortions, and stillbirths. Now, granulomatosis infectiosepticum is a vaginal transmission to the infant, causing an early onset sepsis or neonatal meningitis. Listeria is a common cause of meningitis in the elderly, immunosuppressed, pregnant women, and infants. Listeria monocytogenes is causing meningitis among the elderly, immunocompromised, pregnant women, and infants. So taking us right on to leprosy, or Mycobacterium leprae. This is an acid-fast rod. It's also known as Hansen's disease. Hansen's disease, and it's an acid-fast rod, an obligate intracellular parasite. It prefers cooler temperatures, so it's going to tend to spare the groin and the axilla. Now, there's two disease states. There's tuberculoid and lepromatous. Now, the tuberculoid has a vigorous cell-mediated immune response to infection, so you're going to get a reactive skin test with the tuberculoid form. Because it predominantly activates Th helper 1 cells, which activate cell-mediated response, which have varying effect defense against intracellular bacteria. Now, the lepromatomatous disease is a minimal cellular immune response, so you're going to get a non-reactive skin test because it predominantly activates Th2 helper cells, which activate the humoral response, which is ineffective defense against the intracellular bacteria. It's rarely fatal if untreated. The most common morbidity, though, is an ulnar nerve injury. Ulnar nerve injury, especially in the tuberculoid form. And that's Mycobacterium leprosy for you. So what about Mycobacterium tuberculosis? Well, we know this is an acid-fast rod, which just means it's red, which you can see right here in the picture. These little red guys. And this picture right here, the reason I put it on here is you will see it over and over. You have to recognize that's tuberculosis. And they're obligate aerobe. So they are transmitted, TB is transmitted via aerosol respiratory droplets. It's asymptomatic, and its latent infection is most common. Latent infection is most common. So what about primary TB? It occurs in previously an unexposed host. So you do a diagnosis through skin conversion, which will be a PPD positive skin test or chest X-ray demonstrating a rank complex. A rank complex, or also you could say gone complex, or gone focus. Don't worry, we're going to talk about each one of these. A Ranke complex is a gone complex that has undergone progressive fibrosis and subsequent calcification, which makes it radiologically detectable. A gone complex is a gone focus plus regionally, usually perihilar, lymphadenopathy. Now, a gone focus is a granuloma located near the pleura in either part of the lung or the lower lobe, or the lower part of the upper lobe. The center of the gone focus often undergoes caseous necrosis. So it's the gone focus that undergoes caseous necrosis. Most cases heal by fibrosis, right? It's the only way to solve. It's a chronic disease. So patients gain hypersensitivity and immunity. Remember, the reaction is read by measuring the diameter of induration. I'm talking about the PPD test here. Palpable raised hardened areas. So the redness should not be measured, is another words of saying that. Now you can have something called miliary tuberculosis. Miliary tuberculosis, also known as disseminated tuberculosis. This is a form of tuberculosis that is characterized by a wide dissemination into the human body and by the tiny size of the lesions. The prognosis is poor with 100% fatality if not treated. Now, we can have a reaction of latent TB or latent infection due to immune suppression such as age, drugs, malnutrition, all leading to secondary TB. So this one on chest x-ray, you look for fibrocaseating cavitary lesions in the upper lobes. Why? Because TB is an aerobe. He wants to move up where there's oxygen. Alright? So you look for it in the upper lobes. The reactivation rate in all persons is about 10% per lifetime. Reactivation rate in HIV infected is about 10% per year. So HIV, 10% per year. They want you to know that number, so remember that. In HIV, it's 10% per year. Now, TB can spread to other organs, so extrapulmonary TB may with many different effects. Okay. Now, the goals of tuberculosis treatment are to quickly remove active bacteria, so kill as many latent bacteria as possible and avoid emergence of drug-resistant strains. So use multi-drug regimens is what we do. Now, the treatment is with RIPE therapy, and what that stands for RIPE therapy is rifampin, isoniazid, pyrazinolamide, and ethambutol. So that is usually the combination of drugs that we use to treat tuberculosis. So that's Mycobacterium tuberculosis for you in a nutshell. So now let's move on to Mycoplasma pneumonia. Alright, the membrane of Mycoplasma pneumonia contains something interesting. It contains cholesterol. It contains cholesterol. Now, Mycoplasma pneumonia grows on Eaton's agar with characteristic fried egg appearance. Okay? So, Mycoplasma pneumonia has no cell wall. Now, it's the most common cause of walking pneumonia. Now, walking pneumonia is atypical pneumonia. It disproportionately affects 18 to 24-year-olds living in dorms or barracks. Dorms or barracks. Now, the chest X-ray findings of atypical pneumonia include a vague, ill-defined, or patchy opacities. They usually look worse than in patients who often present with mild fever, non-productive cough, and constitutional symptoms like headaches, diaphoresis, etc. Other common causes of walking pneumonia include Legionella and C. pneumonia. Diagnose this guy, you do a serum cold agglutinin. It is nonspecific but generally positive in patients with the infection. Now, a negative test does not rule out a mycoplasm as a potential cause. And how do we treat it? We treat it with a macrolide. We treat it with a macrolide, a tetracycline, and or a fluoroquinolone. And that is Mycoplasma pneumonia. So let's talk about Neisseria. Neisseria is a gram-negative intracellular diplococci, and he is oxidase positive. Now he's a glucose fermenter, and an IgA protease secretion. Now, Neisseria gonorrhea has no capsule, no polysaccharide capsule, no maltose fermentation, and there is no vaccine. So patients with gonorrhea can also develop pelvic inflammatory disease and septic joints. I'd like to test you on this. Septic joints. Newborns can contract neonatal conjunctivitis from the birth canal. Signs and symptoms develop 3 to 5 days after birth. You can use prophylactic erythromycin ointment can be administered at birth, and silver nitrate can also be used, but is known to cause chemical conjunctivitis. So you look for chlamydia co-infection with Neisseria gonorrhea. Now, what about Neisseria meningitidis? Neisseria meningitidis has a polysaccharide capsule. It does ferment maltose, and there is a vaccine available. Humans are the sole reservoir. Now, the transmission is through nasopharyngeal aerosol secretions. Now, the capsule is what's going to inhibit phagocytosis. So the bacterium release their outer membrane fragments called blebs during growth, which contain lipo-oligosaccharide, or LOS, that have a role in the pathogenesis of shock if they are disseminated. Now, infection starts with a prodrome. So you get cough, headache, sore throat, etc. It can very rapidly progress to fulminant meningococcemia or meningitis if left untreated, and even DIC. Okay? Now there's something called Waterhouse Fredrickson syndrome. Waterhouse-Fredrickson syndrome is a hemorrhage into the adrenal glands. Now, if you hemorrhage into the adrenal glands in the setting of meningococcemia, it's characterized by petechiae, palpable purpuric hypotension, and shock. Okay, you can't keep up your cortisol, you can't keep up your aldosterone production, so your potassium is going to be high, your sodium is going to be low, etc. So that's Waterhouse-Fredrickson syndrome. So if you see somebody with a fever, don't overlook that. That was with Neisseria meningitidis, not Neisseria gonorrhea. Okay, now let's move on to Nocardia astrocoides. So Nocardia astrocoides is a gram-positive rod. He forms long branching hyphae, just as who? Actinomyces. Actinomyces. He is a strict aerobe, partly acid-fast, and catalase positive. He causes 3 categories of disease. That is number 1, cutaneous. Number 2, pulmonary. Number 3, disseminated. So the disseminated would be like the brain or the meningeal involvement. So the cutaneous disease is like abscess or cellulitis secondary to trauma in immunocompetent patients. Now, you can have a slowly progressive pneumonia in immunocompromised patients, so this is an opportunistic infection. So if it's inhaled from the environment, such as soil or water, it becomes a chronic lobar pneumonia, which clinically is going to resemble what? TB. So it may spread from the lungs to form metastatic abscesses in the kidney and the brain. Now, the treatment of choice for Nocardia astrocoides is, without a doubt, TMP-SMX, which is a sulfonamide. Remember that sulfonamides treat nocardia, and what treated actinomyces? Penicillin. Penicillin for actinomyces. Very good. So what about Pseudomonas aeruginosus? He's a fun one. Pseudomonas aeruginosus, I want you to know, is motile, a motile gram-negative rod. He has non-lactose fermentation ability. He has a blue-green pigment in color due to pomycinin, and he has a yellow-green fluorescence under UV light due to proviridin. It can be used to detect early skin infection in burn patients, proviridin. So there's a characteristic sweet odor. It has a type 3 secretion system, which is found only in some pathogenic gram-negatives. No gram-positives have a type 3 secretion system. I'm sure a lot of people haven't heard of that type 3 secretion system. And remember, proviridin is how you can use to detect early skin infection in who? Burn patients. Very good. So this type 3 is not found in no gram-positives. Now, other pathogens with this system include enterohemorrhagic E. coli, Salmonella, Shigella, Chlamydia, Yersinia, etc. He is an obligate aerobe, like Nocardia, Mycobacterium, and Bacillus. He's oxidase positive and non-fermenting. So example would be lactose. He is, though, an opportunistic infection, as I said, especially in burn patients. Number one. Cystic fibrosis patients. Number 3, diabetics. He is an opportunistic infection at best. Or a very, very good one. The pain in the butt. It involves any part of the body and can become disseminated or bacteremic. Now, pneumonia in cystic fibrosis, like I said, in mechanically ventilated patients, leading to death in cystic fibrosis patients. It can cause osteomyelitis in the diabetics or the IV drug abusers. Now, it also can cause black necrotic skin lesions, which is ecthema granulosa. It can cause otitis externa, not interna, but externa, which is pain, pruritus, ear discharge. And in the hospitally acquired, it can cause hospital-acquired UTIs. Now, the clue for Pseudomonas is going to be somewhere near a hot tub or a swimming pool. Swimming pool folliculitis. All right, thanks, Pseudomonas. Now, anti-pseudomonal antibiotics include ticaricillin, carbapenicillin, and piperacillin. The main one that I always remember is piperacillin. It acts as the same mechanism as penicillins, but it uses a beta-lactamase inhibitor known as clavulanic acid, which is synergistic activity with aminoglycosides. So that's Pseudomonas aeruginosus for you. So now let's talk about the rickettsial organisms. They are obligate intercellular parasites. Obligate intercellular parasites which produce coenzyme A and NAD. Other obligate intercellular pathogens include Chlamydia, Coxiella, and Ericoli. They are transmitted through arthropod viruses, except for C. burnettii, which causes Q fever, which is transmitted by aerosol inhalation. So how do we treat it? We treat it with doxycycline. We treat rickettsia infections with doxycycline. So what about Rocky Mountain spotted fever? This is caused by Rickettsia rickettsii, which is a tick. So the signs and symptoms include acute onset fever, headache, myalgias, 2 to 6 days after the onset of the infection. A maculopetechial rash starts on the hands and feet. Hands and feet rash then moves to the trunk. Note the infections that cause palm and sole rashes can be remembered pretty easily. It's just Coxsackie A, Rocky Mountain spotted fever, and secondary syphilis. Okay? Now, let's talk about Q fever with Coxiella burnettii. The Q fever with Coxiella burnettii, you look for pneumonia plus hepatitis and no rash. You look for no rash. Now, typhus can be caused by Rickettsia prowazekii, which is body lice, Rickettsia typhi, which is a flea, or Orchientia pseudoshigashimashi, which is a chigger-borne, formerly known as Rickettsia tugushamushi. Yeah. Okay. They test me on that. I'm punting that. But whatever. At least we went over it. Salmonella. Salmonella is a non-lactose fermenter, same as, you name me 3 others. Proteus, Shigella, and Yersinia. Very good. Now the infectious dose is in the 100 to 1,000 cell range. He is gram-negative and he is motile. He's a gram-negative facultative intracellular anaerobe that is motile, and he produces H2S. Hydrogen sulfide, versus Shigella, which does not. Shigella does not produce hydrosulfuric acid like Salmonella does. Now the transmission of non-typhoid Salmonella is via contaminated food and water. Food and water, like eggs, poultry. Also occurs via direct contact through reptiles and amphibians. Reptiles and amphibians. So what do we know about typhoid fever or Salmonella typhi? Humans are the sole reservoir, and this occurs through fecal-oral transmission. Fecal-oral transmission. Signs and symptoms occur 5 to 21 days post-exposure, and the prodrome is abdominal distension, pain, hepatosplenomegaly, a rash known as rose spots, constipation, and a pea soup diarrhea. I'm not kidding, that's literally your buzzword, pea soup diarrhea. Carriers, example, like Typhoid Mary, can harbor Salmonella in the gallbladder and shed bacteria for years. good old typhoid Mary. So there are carriers of salmonella, and they can shed the bacteria for years upon end. So treatment of both types, typhoid and non-typhoid, include, you got it, the fluoroquinolones. The exception is uncomplicated non-typhoid salmonellosis, in which antibiotic therapy is not recommended. So be careful of that. So uncomplicated non-typhoid salmonellosis. No antibiotics. Okay, so Shigella infection. What's special about Shigella? Well, he's a gram-negative rod, a facultative anaerobe. He is a non-lactose fermenting, which is the same as Salmonella and Yersinia. He's non-motile and does not produce H2S, hydrosulfuric acid, versus Salmonella, which is motile and produces hydrosulfuric acid. So, infection occurs with as few as 10 organisms. Actually, it's 8 to 10, but 10 organisms. That's usually if you get in 10 organisms of whatever inside you, it doesn't set off an immune response. So it evades the distal ileum, or it invades the distal ileum and colon, inducing a phagocytosis by intestinal epithelial cells, which causes escape of endocytotic vesicles. So it replicates intracellularly. Spreads cell to cell. It releases something called the Shiga toxin. Molecularly similar to enterohemorrhagic E. coli virotoxin, which leads to, you got it, diarrhea. And specifically bloody diarrhea, so dysentery, and it's usually acute. So causes of acute bloody diarrhea that is not self-limiting. Early non-bloody voluminous diarrhea caused by an enterotoxin in the small intestine is what leads to dysentery, which is blood and pus in stool. It occurs with later colonic involvement. So that is Shigella. You will see fecal leukocytes present in the stool. And look for dysentery really quick. So it's either you've got it down to EHEC and Shigella if you're talking about dysentery. And the difference between Salmonella is he produces H2S. So Staphylococcus aureus. Staphylococcus aureus is a gram-positive cocci in clusters. He's catalase positive, coagulase positive, beta hemolytic, and he forms yellow golden colonies. Ri means golden. To differentiate Staph aureus from other bacteria, Staphylococcus is in clusters versus Streptococcus is in chains. Okay? Staph is catalase positive versus Strep is catalase negative. Staph aureus is coagulase positive versus Staph epidermidis and Staph saprophyticus are coagulase negative. They don't have the coagulase to eat through your blood. Staph aureus is the most common cause of hospital-acquired bacterial pneumonia, ventilator-associated And number 5, impetigo. So those are the 5 things that Staph aureus is the most common cause of. Hospital-acquired bacterial pneumonia, ventilator-associated bacterial pneumonia, cellulitis, osteomyelitis, and impetigo. So let's go back here. What's its major virulence factor? What's its major thing that it has that nobody else does? It's this protein A. Major virulence factor is protein A, which binds to the FC region of IgG, thereby inhibiting complement fixation. So what tissue and organs does this infect? Well, you're going to get a pneumonia. You're going to get osteomyelitis because Staph aureus is the most common cause. You're going to get acute endocarditis, classically an IV drug abuser. Staph aureus is the most common cause of acute endocarditis versus subacute endocarditis, which is most commonly caused by Streptococcus viridans, subacute Streptococcus viridans, acute endocarditis, Staph aureus. Also foreign bodies like prostatic valves, pacemakers, central lines, catheters, etc. Although Staph aureus can colonize foreign bodies, Staph epidermidis is more classically associated with colonization of foreign bodies and iatrogenic infection. An infection with Staphylococcus aureus will cause a tissue abscess, tissue abscesses, and soft tissue infection leading to a cellulitis. So the Staphylococcus aureus exotoxin-mediated diseases is toxic shock syndrome, scalded skin syndrome, and food poisoning. So Staph aureus infections can be treated with antibiotics, but the exotoxin-mediated effects persist. The toxins include the TSST1, enterotoxin, and they're both superantigens. They're both superantigens. So the mechanism by which this works is by superantigens cross-link the alpha chain of the MHC2 on the antigen-presenting cell, like the macrophage or the dendritic cell, with the variable region of the beta chain, the V variable region, on T cell receptors on CD4 T helper cells. So that becomes polyclonal, which is antigen independent, and you get T helper cell activation, therefore increased IL-2 and interferon gamma, which activate who? Macrophages. So you get an increased pro-inflammatory cytokine release of IL-1, IL-6, and tumor necrosis factor alpha. So superantigens do not activate all CD4 T helper cells. Different superantigens are specific for different variable beta chains and activate different subsets of CD4 T helper cells. So that is Staph aureus, and he is methicillin resistance is conferred by altered penicillin binding proteins. That is true. So how do we treat it then? Well, vancomycin or lysonomide are the two I want you to remember. Vancomycin and lysonomide. Vancomycin is a glycopeptide antibiotic. Lysonomide is an oxynolitidone antibiotic class. You can also use daptomycin. You can also use quinupristin. or tiglycine. Tigecycline. So the two to remember, vancomycin and lysomelid. Those are the ones that you need to know for the methicillin resistance conferred by the altered penicillin binding proteins. So moving right along, staph epidermidis, staph epidermidis is a gram-positive cocci in clusters. He is a catalase positive. All staphylococci make catalase, but he is coagulase negative versus who is coagulase positive? Staph aureus. He is non-hemolytic and he forms white colonies, originally named Staphylococcus albus because albus means white. So he is novobiacin sensitive. He's novobiacin sensitive and can be used to distinguish Staphylococcus epidermidis from Staphylococcus saprophyticus. Because Staphylococcus epidermidis is novobiacin sensitive, Staphylococcus saprophyticus is novobiacin resistant. So staph epidermidis is considered normal skin flora. Staph epidermidis is considered normal skin flora and is notorious for contaminating what? Blood cultures. Now, staph epidermidis is capable of getting a sticky, protected biofilm facilitating colonization and infection in prosthetic devices. Prosthetic devices, including prosthetic heart valves and indwelling urinary catheters. Indeed, staph epidermidis is the most common cause of prosthetic valve infective endocarditis. And there you go. That's staph epidermidis for you. So strep pneumo. So strep pneumo or pneumococcus is a lancet-shaped gram-positive cocci in pairs, which means diplococci, or chains. He is catalase negative, alpha hemolytic, meaning partial or greening hemolysis. Greening hemolysis. So green rings form around colonies when plated on blood agar. He is biosoluble, so he's susceptible to lysis by bile. He cannot be cultured in bile. He's optocin sensitive, so he's susceptible to lysis by optocin, so he cannot be cultured by optocin either. Now, compared to the viridans group streptococci, like strep pneumonia, viridans group streptococci are gram-positive cocci in pairs or chains. They're coagulase negative, they're alpha hemolytic, but unlike strep pneumo, however, viridans group streptococci are bile resistant. They are not susceptible to lysis by bile. So strep viridans is bile resistant and optocin resistant. They are not susceptible to lysis by optocin. They can grow in the presence of optocin. So let's talk about the virulence factors of strep pneumo. You have an IgA protease and a polysaccharide capsule, which is anti-phagocytic. The IgA protease cleaves secretory IgA in where? Mucus. So 5 to 10% of adults have nares colonized with pneumococcus. 5 to 10% of adults have nares colonized with pneumococcus. I know. Encapsulation, asplenic patients, such as a sickle cell or splenectomy patient, are at increased risk for sepsis. So you need to prophylactically vaccinate these patients is the considered standard of care. Strep pneumo is the most common cause of meningitis, otitis media, community-acquired pneumonia, and sinusitis. Also, a classic finding of pneumococcal pneumonia is rusty colored sputum. That's a good clue for you on the boards. Rusty colored sputum is a classic finding. Now, let's compare Strep echolectiae, which is group B Streptococcus, which is the most common cause of pneumonia in newborns. Streptococcus echolectiae. Streptococcus echolectiaceae. Also compared to RSV, which is the most common cause of pneumonia in children. Respiratory syncytial virus. Guess I should write these down for you. Most common cause of pneumonia in newborns. RSV. In children. And mycoplasma is the most common. And pneumonia in adults less than 40 years of age. So you need to think about those on your differential. And remember, what was another name for group B strep? Strep echolectiae. So Streptococcus pneumonia is the most common cause of meningitis in young children. Most common cause of meningitis in young children. Strep pneumonia, pneumococcus. All right. So let's talk about strep pyogenes. But before we do that, there's one thing else I want to talk about that you need to know for the boards. The capsule, compared to the meningitis, Neisseria meningitis is the most common cause of meningitis in patients 6 to 59 years old. So if it's a young child, you say strep pneumo. And Streptococcus echolectiae, or group B strep, is the most common cause of newborns less than 6 weeks of age. So the great majority, Neisseria meningitis. Capsule polysaccharides from different strains of strep pneumo are mixed together to form a multivalent pneumococcal vaccine, which come in two forms, conjugated and polysaccharide only. Okay, so number one, it's the PCV13, which is pre-Vinar 13, which is 13-valent pneumococcal conjugate vaccine. Recommended in children's 6 weeks to 5 years age. Number two, we have the PPVSV, which is the Pneumovax. And this is a 23-valent pneumococcal polysaccharide. Polysaccharide vaccine. And that's recommended for adults greater than 65 or 65 years of age. So that's what you need to know about that. So strep pyogenes, what do we know about strep pyogenes, or group A strep, or GAS? Strep pyogenes is a gram-positive cocci in pairs and chains. He's beta hemolytic. He is bactration sensitive, and he has a hyaluronic acid capsule, which is antiphagocytic, and he also has an M protein, which inhibits opsonization. So he's a bad little boy, strep pyogenes. Now, the strep pyogenes toxins. There's 3 pyrogenic exotoxins, also called SPEs, for scarlet fever toxins and erythrogenic toxins. They're recognized by types A, B, and C. A, B, and C. These toxins are called superantigens. So you got SPEA, and SPEC, and SPEB. So ABC. Now, the A and the C are encoded by lysogenic phages. They're responsible for the rash and scarlet fever and many symptoms of toxic shock-like syndrome. SPEB is a protease precursor that becomes activated to a cysteine protease. So it's a gene for SBE, or for SPEB, is located on the bacterial chromosome. So it's associated with necrotizing fasciitis. SPEB. Strep pyogenes enzymes. These include the hyaluronidase, which facilitates spread through tissues, which is how you get cellulitis. It also has streptokinase, which is a fibrinolysin. It has streptolysin O, which is a oxygen-label beta hemolytic antigenic titer, important for the diagnosis of rheumatic fever, the streptolysin O. And it also has streptolysin S, which is an oxygen-stable beta hemolytic but non-antigenic. So infections caused by Streptococcus, let's see here. So infections caused by strep pyogenes, that would be pharyngitis, which is strep throat, impetigo, and erysipelas and cellulitis. And that is strep pyogenes, or group A strep. Now, toxin-mediated diseases of you know what, before we go on to that, let's go back to infections caused by strep pyogenes. Infections caused by this, infections near fascia are what lead to necrotizing fasciitis. Note there are many infections causing necrotizing fasciitis, which include Clostridium perfringens, MRSA, and mixed anaerobic infections. However, group A strep is very commonly tested organism. So the impetigo, that's going to be your honey-colored crust. So strep pyogenes may cause either a non-bullous impetigo or a bullous impetigo. Although histologically strep pyogenes was the most common cause of impetigo, strep pyogenes is now a rare cause of bullous impetigo in the U.S. Staph aureus, note that Staph aureus is currently the most common cause of both non-bullous and bullous impetigo in the United States. So pick Staph aureus on your exam. Now, the strep pyogenes is the most common bacterial cause of the sore throat, pharyngitis, strep throat, sore throat. So fever, malaise, sore throat, physical exam, you're going to see tonsillopharyngeal erythema and exudates, as well as tender cervical lymphnopathy. So let's talk about those toxin-mediated diseases caused by strep pyogenes. These are scarlet fever, toxic shock-like syndrome, necrotizing fasciitis. So toxins involved in scarlet fever and toxic shock-like syndrome are the SPEA and the SPEC. Both are super antigen exotoxins. So the toxic shock-like syndrome differs from Staph aureus toxic shock syndrome because toxic shock-like syndrome from Strep Escherichia or Group A strep presents with extremely painful pre-existing skin infections. Now, blood cultures are typically positive in toxic shock-like syndrome versus negative blood cultures in Staph aureus toxic shock syndrome. So let's talk about scarlet fever. Scarlet fever gives you, number one, a fever, pharyngitis or sore throat, strawberry tongue, remember that. So don't just go to Kawasaki's disease when you hear strawberry tongue, but it may be seen in Kawasaki's disease. Number four, a confluent erythematous, sandpaper-like, which is a flying and branching rash that begins on the chest and neck and spreads to the rest of the body. May also give you a circummural power, which is a rash that spares the nasolabial triangle and the chin. Can also give you something called pastilla lines, which is an accentuation of a rash and a linear pattern along skin folds. That's pastilla lines. Pastilla lines or circummural pallor, which is a rash that spares the nasolabial triangle and chin. So the toxin associated with necrotizing fasciitis was SPEB. Very good. Now, autoimmune diseases include rheumatic fever, which is a type 2 hypersensitivity, post-streptococcal, glomerulonephritis, which is a type 3 hypersensitivity. Rheumatic fever is caused by cross-reactivity of strep pyogenes antigens, especially the M proteins and self-antigens. 80% of cases in children are present with 2 to 3 weeks post-infection. To diagnose rheumatic fever, you must have evidence of a recent strep infection. The serology is an ASO titer, an anti-DNase B titer, and etc. So you got to have at least 2 major Jones criteria, or 1 major criteria and 2 minor Jones criteria. So I'm not going to go through and bore you with the Jones criteria. You can learn that for step 2 and all that good stuff. So let's compare a little bit and contrast. So strep viridans is alpha hemolytic, apoptogen resistant. Actually, let me write this in there for you. So Viridan strep So we have strep viridans, which is alpha hemolytic, apoptogen resistant, no polycyte capsule, and he's not biosoluble. Whereas now strep mutans and strep sanguis are both members of the viridans group Streptococcus. So that strep mutans is associated with dental caries, and strep sanguis is associated with subacute bacterial endocarditis. Now, strep pneumonia, he was alpha hemolytic, was strep viridans. He's apoptogen sensitive, whereas strep viridans was apoptogen resistant. He also has a polysaccharide capsule, and he is biosoluble. So strep viridans is the exact opposite of strep viridans, except they're both alpha hemolytic. Now, strep pneumonia is also the most common cause of meningitis, otitis media, sinusitis, and community-acquired pneumonia. You contrast these 3 with strep pyogenes, which is group A strep, beta hemolytic, bactracin sensitive, high hyaluronic acid capsule, which is antiphagocytic, and an M protein, which opsonizes bacteria. So there you go. So let's talk about strep viridans. Strep viridans is a large group of commensal, meaning non-pathogenic, bacteria. Now, strep mutans causes dental caries, whereas strep sanguis is the most common cause of subacute bacterial endocarditis. Where strep mitans now, mites or mitans, strep mitans may also cause bacterial endocarditis as well. I just want to put that in there. It's apoptogen resistant, which differentiates from apoptogen sensitive strep pneumonia. It has no capsule, which differentiates it from high hyaluronic acid capsule of strep pyogenes, or the strep pneumo polysaccharide capsule. It is alpha hemolytic. An alpha hemolytic, just like strep pneumo, but it differentiates from the beta hemolytic strep pyogenes and strep escherichia. It is not biosoluble. Example, it's not susceptible to lysis by bile, versus strep pneumo, which is biosoluble. And that is pretty much strep viridans for you in a nutshell. Just remember, it causes dental caries. What about Treponema pallidum? This is a spirochete that causes syphilis. Now, besides Treponema pallidum, there are other spirochetes, including Leptospiraea and Borrelia, but Treponema pallidum can be visualized by dark field microscopy. So let's talk about primary syphilis. So primary syphilis is going to have a painless chancroid. Now secondary syphilis is going to become 1 to 6 months later, and it's going to be a symmetric non-pruritic rash on the palms and soles of the feet. This rash can be macular, papular, or pustular in appearance. And condyloma lata are smooth, flat lesions that occur in moist, intertriginous regions like perianal areas, vulva, scrotum. Contrast to condyloma lata caused by secondary syphilis with condyloma acuminata, which is venereal or genital warts. And tertiary syphilis occurs 1 to 10 years later. Now that's where you get a gumma formation. A gumma formation, or it's basically granulomas in the bones. It's a gumma or gumma. And you also get aortitis. The dorsal columns demyelinate, so you get neurosyphilis, also known as tabes dorsalis. You get Argyll-Robertson pupil, where it accommodates but it does not react. They call it the prostitute's pupil. You get a broad-based ataxia, and a lot of these people have a stroke with tertiary syphilis. Now, congenital syphilis is the S in Torch's infections, which I know we've all heard of. It's a common mnemonic used to remember the infectious agents, which may do what? Cross the placenta and cause congenital infection. Now, those are toxoplasmosis, rubella, CMV, HIV, herpes virus, and syphilis. So initially following birth with congenital syphilis, it may manifest as persistent rhinitis, lesions of the palms or soles, or both, hepatosplenomegaly and jaundice, and hemolytic anemia or thrombocytopenia. Now, features which may manifest later after the age of 2 years in the course of congenital syphilis include interstitial keratitis, deafness, CNS damage, frontal bossing, Hutchinson's teeth, Murbury knot molars, periorbital fissures, high arch palates, saddle nose, saber shins, etc. So the first thing you do in the diagnosis is you screen for the VDRL, which is Venereal Disease Research Lab, or the Rapid Plasma Regan test, or the RPR test, which are relatively sensitive tests for syphilis. And that was the VDRL. Or the RPR. Either one of those will work for syphilis. Now, if the VDRL or RPR tests are positive, then confirm with a FTA-ABS. That's what you confirm it with, the FTA-ABS, which stands for fluorescent treponemal antibody absorption test, which is a very specific test for syphilis. The FTA-ABS. So, Vibrio cholera. What do we know about some Vibrio? Vibrio cholera is a common-shaped gram-negative rod. He is motile and he is oxidase positive. He's similar to who? Pseudomonas aeruginosus, Clostridium jejuni, and H. pylori, which are also motile oxidase positive gram-negative rods. Except there's one little exception there that I said. What's Pseudomonas shaped like? Well, he's shaped like a comma. Now, before we get to the fecal-oral transmission, these have yellow colonies on the TCBS, which is the thiosulfate citrate bile salts sucrose agar. Okay, so they're yellow colonies on the TCBS agar. They are not normal flora. Vibrio cholera are not normal flora. You get these by fecal-oral transmission. A large inoculum of Vibrio cholera must be ingested to overcome the gastric acid and cause infectious diarrhea. 10 to the 8th or 10 to the 10th Vibrio cholera organisms must be ingested versus Shigella, where it's 10 to the 1st, and Salmonella, where it's just 10 to the 2nd or 10 to the 3rd. So you got to get inoculated pretty good to get hit with this guy. Now, Vibrio cholera does not invade the GI mucosal or blood, so there's no fecal leukocytes and there's no bacteremia. So bacteria that cause diarrhea ordered by increasing invasiveness are ETEC, enterotoxic E. coli, and Vibrio. Another one is enterohemorrhagic E. coli, which is EHEC. It invades the colonic mucosa but not blood. And Shigella invades the colonic mucosa and rarely blood, but the invasive one is Salmonella typhi, which invades both mucosa and blood, so you get a positive blood and stool culture. Strains infected by the lysogenic bacteriophage produce the cholera toxin. The cholera toxin. Now, the cholera toxin is a heat labile AB exotoxin. AB exotoxin that ADP ribosylates. ADP ribosylates and activates GSQ. So you increase cyclic AMP because of this. You increase cyclic AMP, which opens the CFTRs in the luminal membrane of the gut epithelial, so you get an increased chloride secretion. Into the gut lumen, which causes an increased secretion of, you got it, bicarb. And that right there is what really gets you, sodium and then water. So you get a voluminous, watery diarrhea up to 30 milliliters a day with visible flakes of mucus in the epithelial cells. So they call it a rice water stool. Rice water stool with Vibrio cholera. Note, the CFTR is the cystic fibrosis transmembrane conductance regulator, an ABC or an ATP binding cassette transporter encoded on chromosome, you tell me, 7, you have to know that is implicated in the pathogenesis of cystic fibrosis. So what would the treatment for Vibrio cholera be, doctor? What do you think? Fluid and electrolyte replacement. Very good. All right. Moving right along. Yersinia intercolitica. This is a non-lactose fermenting gram-negative rod, motile at 22 degrees. So what he does is he penetrates the intestinal epithelium at the terminal ileum and he colonizes Peyer's patches and causes a terminal ileitis. And that can mimic what? Appendicitis. or Crohn's disease. Crohn's disease. Transmission is from animal feces, so like fingers or food, especially milk. Outbreaks occur a lot in daycare centers. That's a big clue for you on the board. So be thinking about Yersinia enterocolitica. Outbreaks occur in daycare centers. Simple enterocolitis or mesenteric adenitis does not require treatment but is self-limited. Okay? So that's Yersinia enterocolitica for you. So what about Yersinia pestis? Yersinia pestis is a non-motile, pleomorphic, non-sporulating, gram-negative bacillus. Gram-negative bacillus that belongs to the Enterococci family. Now, the Weissenstein, that's right, Weissenstein, the Weissenstein demonstrates a typical safety pin appearance, which is called bipolar staining. Bipolar staining. Rodents, especially prairie dogs, that is what are prone to Yersinia pestis infections. There are 3 common modes of transmissions to human. A flea bite, so a flea bites an infected animal and then the human host, or respiratory droplets from an infected host, or direct contact with infected tissue or fluid are the 3 modes of transmission to humans of Yersinia pestis. Remember, this is what caused the bubonic black plague that killed millions. Now, there are chromosomally encoded virulence factors. One is an LPS, endotoxin, an HMS, which is a hemonin storage molecule, and a PSA, which is a pH6 antigen. Now, the LPS activates macrophages, which release their IL-1, their TNF-alpha, and their NO, which activates the what? The alternative complement pathway, and activates Hagman factor, or coagulation 12, factor 12, that can eventually lead to, you got it, DIC. Very good, DIC. That's the chromosomally encoded virulence proteins. Now, the plasma-encoded virulence proteins are a little different. Now, the plasma-encoded proteins are YOX, which is Yersinia outer membrane proteins, YSC, which is Yersinia secretion, a type 3 secretion system, type 3 secretion systems are only found in some pathogenic gram-negatives of note. Yersinia pestis is one of them. Can you name me a couple others? Shigella, Salmonella, Enterohemorrhagic E. coli, Chlamydia, Pseudomonas, etc. The V antigen and the W antigen. Now, those are protein-lipoprotein complexes that prevent phagocytosis. The V antigen promotes survival in macrophage. Then you also have the PLA, or the outer membrane protein plasminogen activator, a protease that degrades fibrin and other extracellular proteins and interferes with blood coagulation and complement activation pathways. And then number 5, you have F1. F1 is a capsular protein fraction 1, and it is anti-phagocytic. The anti-phagocytic components of F1 and the VW antigens are only produced when the organism grows at 37 degrees Celsius. 37 degrees Celsius, which might explain why the bacteria are not virulent in the flea, which has a body temperature of near 25 degrees Celsius. We've always wondered that, but that would explain it. So Yersinia pestis infections takes three main forms. The pneumonic, the septicemic, and the bubonic plague. Now, clinical symptoms are varied, but the bubonic plague is characterized by fever, headaches, adenopathy of the lymph nodes. They call those what? Buboes. The treatment is streptomycin, formerly the drug of choice, but now gentamicin is really the one I would pick on the boards, but it could be streptomycin or gentamicin. I doubt they do both to you. And post-exposure prophylaxis, we use doxycycline and tetracycline. All right, so that takes us into the Group B Streptococcus, or the Group B Strep This typically causes perinatal disease. 25% of pregnant women have vaginal or rectal colonization here. So you look for pneumonia, meningitis, and sepsis. Those are the three things you look for. It's bactration resistant, catalase negative, beta hemolytic, and has a positive C-amp test. The cyclic AMP factor enlarges the area of hemolysis formed by the beta hemolysin from Staphylococcus aureus. So that is Group B strep for you. Now we're going to do a summary of the toxins.